and we are live. We are just waiting for attendees to join the room. We'll get started in just a minute.
Good afternoon, everyone, and welcome to our first webinar on the Trusted Exchange Framework and the Common Agreement, Draft 2. My name is Elise Sweeney-Anthony, and I am the Executive Director of Policy here at the Office of the National Coordinator for Health Information Technology. Today, we'll be presenting on Draft 2 of the Trusted Exchange Framework and Common Agreement. Just a couple of housekeeping components. First, the deck that we will be presenting on today will be available on our website, healthit.gov/TEFCA, T-E-F-C-A. And of course, the comment period is now open. Please submit any comments you have through that process. Let me go ahead and turn it over to our National Coordinator for Health Information Technology, Dr. Donald Rucker.
Elise, thanks. Well, welcome everybody. Thank you very much for participating in this webinar. We are, in the spirit of maximal collaboration, putting the Trusted Exchange Framework and the Common Agreement out for another round of public comment. There's a lot of technical complexity here, I guess, potentially. We think it's going to have a big impact in the country. And so we wanted to make sure we had all of our country's best thinking on how to put this together. We're obviously very excited. We think health information exchanges have some amazing potential to grow. We see some specific opportunities in expanding into some of the community information exchange. As somebody who's been a long-time emergency department doctor, I've taken care of many, many patients who shuffle between known healthcare systems like ERs and hospitals and clinics, and then things like group homes, shelters, frankly, jails, schools, in that broader context of healthcare. And we see some interesting opportunities for health information exchange there. You may have seen yesterday, Secretary Azar and Administrator Verma released with Adam Bowler the new primary care value-based compensation model. Health information exchanges play a important role there in linking up the physician practices. So we're very excited. Our second slide here, you have the actual subsection language of that in the Cures Act from 2016. And if we can go to the current complexity slide, Beth. So as we look back to why did Congress pass why did Congress come up with the concept of a trusted exchange framework? And the reason is really because Congress heard complaints that people were being required often at significant expense to join multiple different networks, that the networks didn't talk to each other. And I think that was the root issue being solved here. On the next slide, some of this was related to the costs. We have some data, sorry, on interoperability and the state of interoperability. And obviously there is, as we all know, work to be done to make this be a rich national fabric between all providers, not just certain classes of providers. So that really is part of where we want to be with health information exchange. And on the next slide, you can see the goals, which are really to provide a single ramp to allow, along with the rest of the work we're doing here, is to allow electronic health information to securely follow you wherever you are in the country, and obviously to do this nationally. This is, we think, a complement to the standards-based application programming interfaces that we have in the ONC interoperability rule, for which we just extended the comment period. We thought it was going to be very important for people to be able to look at both things simultaneously in making their comments and thinking about their comments. There's not a lot of direct overlap, as it turns out, but we wanted to make sure that people had them both in mind. And as you may have noticed from last week's announcement, we've worked throughout Health and Human Services with our Office of Civil Rights and Roger Severino's team to clarify that the patient really is king or queen here, as the case may be. The assumption of all of this is the patient is in control of their data. And so part of that, there's a FAQ clarification that when the patient exercises their HIPAA right of access, providers will not be liable. Once the patient downloads their data on an app, it is their data and their responsibility, and issues of secondary use deferred to the patient and the app as opposed to the provider. So I just wanted to point that out. So with that, we will get into some overall details from Elise Anthony and Steve Posnack, and then we're going to have Zoe Barber and Alex Contour dive into the things. If you missed something, you got it all in the slides. And I want to also, while we're transitioning, thank Genevieve Morris, who initiated much of this work when she was Principal Deputy National Coordinator. So with that, we will turn it over to Elise.
Thank you, Dr. Rucker. Next slide. And one more. All right. So first we wanted to start with the Trusted Exchange Framework. And basically, the Trusted Exchange Framework is the common set of principles that we think are necessary to support trust across health information networks. And as you can see, there are 6 principles related to everything from standardization to transparency, addressing cooperation and non-discrimination, even when a stakeholder may be a business competitor. We also include principles around privacy, security, and safety, the access that is provided to ensure that individuals and their authorized caregivers have easy access to their EHI, as well as Principle 6, which is focused on population-level data. Next slide. The Trusted Exchange Framework provides the foundation upon which the common agreement would be built. And on this slide, you can see that the common agreement is composed of the minimum required terms and conditions, as well as the additional required terms and conditions. The minimum required terms and conditions are included in the draft that we released this past Friday and are open for comment. The additional required terms and conditions would be developed by the recognized coordinating entity with the approval of ONC. And together, those would create the common agreement. The QHIN technical framework would be a component of that, in that it would be incorporated or included by reference into the common agreement and provides the technical and functional foundation that would be required for exchange among QHINs. And with that, let me turn it over to Steve Posnack, who leads our Office of Technology, to talk a little bit about the QHIN technical framework.
Thanks, Elise. Hey, everybody, Steve Posnack from OC. Very briefly, I wanted to highlight for you one of the new additions to the TEFCA lineup. We have the QHIN technical framework. Experience has shown that we make the most impact when policy and technology are developed together. And for ease of reference, as you hopefully will see in the way that we've laid out the document, there are the policy components, and then now equally with what we've proposed and included for your comment and feedback is the QHIN technical framework, which really is the kind of guidepost for how qualified health information networks would exchange data among or between themselves, and then subsequently some of the functionalities that they would have to be able to support for their health information network community. I wanted to just do a few more context setting points on the QHIN technical framework overall. It's important to keep in mind that the QHIN technical framework draft 1 is a starting line, is a starting point, not the finish line. Its purpose is to generate feedback for the recognized coordinating entity, who will then be on task to work with industry to make future versions of the QHIN technical framework align with and support the minimum required terms and conditions that are the MRTC's acronym that we've now provided to you all. So there's, again, this blending of both policy and technology together. We've looked at, since we had access to the MRTCs from the start, how we could prompt and start this open dialogue with the community and help it to really jumpstart the RCE's work going forward. And RCE, again, is recognized coordinating entity. You'll be sick of all these acronyms by the end of our presentation today, but wanted to make sure that you had that context for the QHIN technical framework going forward. I now have the privilege of turning it over to our wonderful colleagues, Zoe and Alex, and they're going to cover the top line points across the entire set of documents that we've released for your comment. Take it away, Zoe.
Hi, thank you so much, Steve. My name is Zoe Barber. I'm a Senior Policy Advisor in the Office of Policy here at ONC. And as many of you know me, I lead the development of the Trusted Exchange Framework and Common Agreement. And I'm so excited to be presenting the TEFCA Draft 2 to you all today. I know that this draft has been a long time coming, and we've spent a lot of time thinking through your comments and making updates. And I really think that this draft takes a major step forward in advancing interoperability and nationwide exchange. So first, we're going to talk about some of the major updates from TEF Draft 1 and that have been included in this next draft of the TEFCA. Next slide. So first, I'll say that this is not an exhaustive list of updates, but these are some of the major things that we received comments on. So first, we've updated the exchange purposes that are included in the Common Agreement. Draft 1 proposed 6 purposes for use and disclosure of electronic health information, and that included treatment, payment, healthcare operations, public health, benefits determination, and individual access. Many commenters we found were very supportive of the proposed exchange purposes, but we did receive some feedback that the full healthcare operations and payment purposes could be too burdensome to start off with immediately, and that some of the use cases have not been tested on a wide scale or in a network exchange context. And while we are aiming to expand nationwide interoperability and to establish a single floor of purposes that data can be exchanged on, we do not want to move so quickly that we disrupt current exchange activities and put the health of our participants at risk. So therefore, we are starting with a subset of healthcare operations and payment purposes that we know are being widely used today. And these include conducting quality assessment and improvement activities, business planning and development, and utilization review. We believe that this proposed set will help to support a variety of important national goals, including improving care coordination, care referrals, individual access, prior authorization, and more. But we are requesting comment on the scope of these purposes and their definitions. Next, we've added a new exchange modality called QHIN message delivery. And this supports the ability of a QHIN, or a Qualified Health Information Network, to push a message to one or more specific QHINs for delivery. As you all may remember, Draft 1 was focused entirely on query-based exchange, and we heard from many commenters that a large volume of transactions that occur today are push-based, and that they play a vital role in supporting transitions of care and public health use cases, among others. And therefore, we have added QHIN message delivery and are looking for your comment on its definition. Also, we have removed the population level query use case for this draft. While it's important for modern healthcare delivery and to the Cures Act's modern or long-term goals, the industry is still working to mature this use case in a network exchange context, and we intend to work with the industry to phase in this use case as standards mature. All right, next up, this version of the Trusted Exchange Framework and Common Agreement, as Steve mentioned a minute ago, includes the QHIN Technical Framework, or the QTF, which addresses the technical requirements for exchange among QHINs. And the purpose of this draft one, as Steve mentioned, is really to tee up some of the technical issues that the recognized coordinating entity will work with the industry to resolve. And the RCE will be working with the QHINs and with stakeholders to develop the second draft, which could include new specifications to meet the requirements of the common agreement. Okay, next, in this draft, we have expanded the definition of a QHIN to allow for a much broader range of entities to apply. And one of our most important policy goals for QHINs is to minimize failure and prevent any disruption to the network. Therefore, we've added a lengthy application process that includes a provisional period in which health information networks can onboard and implement all of the requirements of the common agreement before actively exchanging data on the network. This will allow for a competitive marketplace of QHINs while still minimizing failure and ensuring the success of the network. And then finally, in TEF Draft 1, we proposed a period of 12 months for QHINs and others to implement updates to their technological and legal standards. In this draft, we have not specified a time period for the initial onboarding of QHINs, and instead we are going to let the recognized coordinating entity determine timelines for the QHIN application and provisional periods. But once you're signed on to the network, if a new version of the common agreement is released, then you'll have 18 months to make those updates. So if you go to the next slide, you can just see this update process for the common agreement. Once version 1 has been published, ONC may work with the RCE and the industry to identify new requirements or use cases. And to the extent that any are found, the RCE may update the common agreement for ONC approval and publish a new version. At that time, QHINs would have 18 months to comply with any applicable updates in the new version. Next slide, please. All right, next I'm going to talk about a little bit about the structure of the common agreement. Next slide. So first, in order for there to be true nationwide interoperability, all stakeholders should have an equal opportunity to participate in exchange. The TEFCA is designed to be inclusive of many different types of stakeholders, including health information networks, major health systems, small and ambulatory provider practices, public health organizations, payers, government agencies, and of course, technology developers, including new and emerging technologies that allow individuals to access their health information when and where they need it most. And of course, we didn't forget individuals who, per our definition of individual, could include the person who is the subject of the information being accessed, but it can also include a personal or legal representative or any other person who has authority to act on behalf of the patient. Today, many of these stakeholders are not exchanging data with each other for a multitude of reasons, including lack of trust and inconsistencies between data use agreements. So one of our major goals in designing the TEFCA was to set baseline requirements for all types of stakeholders so that all entities involved can readily and efficiently exchange data with each other. Next slide, please. Okay, how will the common agreement work? So many of you have seen this slide before. This shows a holistic view of how all of the different components of the common agreement interact with each other and how the stakeholders that we just discussed can also interact and engage within the network. So we're going to break each of these down, but first, really quickly, the umbrella at the top here represents the industry-based recognized coordinating entity, or RCE, that will provide oversight and monitor QHINs for compliance. In the center, we have our web of QHINs who connect directly to each other to facilitate nationwide interoperability. And then each QHIN represents a network of participants, participant members, and individual users that can represent stakeholders from all across the care continuum. Next slide, please. So one of our major goals in designing the common agreement is to collaborate with the industry and to build a public-private partnership to implement and sustain the common agreement. Therefore, we felt that it would be appropriate to have an industry-based entity implement and monitor compliance with the common agreement. And the RCE will have responsibilities such as developing, updating, implementing, and maintaining the common agreement, identifying, designating, and monitoring QHINs, convening public listening sessions to gather stakeholder input, developing and maintaining a process for adjudicating noncompliance with the common agreement, and proposing strategies to sustain the common agreement at a national level after the initial cooperative agreement period. Next slide. The RCE will be selected through an open competitive notice of funding opportunity, which we have released along with the TEFCA Draft 2 and can be found on both grants.gov and healthit.gov. We are looking for applicants who are nonprofit entities based in the United States and who have experience developing and maintaining large network agreements. It's important to note that the NOFO applications are due June 17th, and we expect to award by late August or early September. And there will be an informational session on the NOFO on April 30th at 2 p.m. Eastern. Next slide. Okay, so next we'll talk about the Qualified Health Information Networks, or QHINs. So in short, QHINs are health information networks with the technical capabilities to connect together multiple disparate health information networks on a nationwide scale. They're the gatekeepers of all of the electronic health information that flows through the network, and thus they have additional responsibilities that allow them to securely exchange large volumes of data from across the country on a daily basis. As you can see here, QHINs connect directly to participants, who can be any person or entity that enters into an agreement to participate with a QHIN. Participants then connect directly to participant members, who can also be any person or entity that has entered into an agreement to use the services of a participant. An individual user is an individual who makes a request for individual access services, which we'll talk a little bit about more later, using the services of a QHIN, a participant, or a participant member. So it's important to note that individual users can connect directly to anyone on the network as long as they provide individual access services. Another thing to note is that we recognize that every health information network serves unique constituencies with differing needs, and therefore we have designed the common agreement in such a way as to not dictate the internal requirements or business structures of the QHINs. So not all QHINs must be composed of the same types of participants and participant members, and depending on its internal structure, there could even be several different amalgamations of participants and participant members within and across QHINs. So if you go to the next slide, here you can see an example where you have a QHIN that is composed of multiple health IT developer participants. The participant members could include providers, consumer apps, pharmacies, or anyone else that uses the health IT developer services. This example also shows that any entity participating under the common agreement, so whether it's the QHIN participant or participant member, can offer consumer-facing services and connect directly to the individual user. And that individual user has the flexibility to choose which services they use and from whom. So if you go to the next slide, you can see another example here where you have a QHIN that has various participants, including federal agencies, health systems, and HIEs. And the members of those participants and those that are using the services of those participants are considered the participant members. Next slide, please. Okay. So this slide illustrates the structure of the legal agreements, or as we like to call them, the framework agreements that will govern the QHINs, participants, and participant members. So the parties to the common agreement itself will be the RCE and one or more QHINs. The common agreement then includes flow-down clauses that apply specifically to the participants and participant members. So QHINs must work with their participants, to develop a new agreement or to modify an existing agreement to incorporate the applicable flow down provisions for participants. So in this version of the MRTCs, that would be Section 7. Then that would be considered, that new agreement would be considered a participant QHIN agreement. And then it would be the QHIN's responsibility to ensure the flow down provisions are incorporated and that the participant is in compliance with the participant QHIN agreement. Similarly, participants and participant members must have a participant member agreement that incorporates the participant member flow down provisions. And in this draft of the MRTCs, that is Section 8. It is then the responsibility of the participant to ensure participant member compliance. Next slide, please. All right, next we're going to talk a little bit about how do you become a QHIN. So next slide. So first, in order to apply to become a QHIN, you must first meet the definition of a health information network. You must also operate an existing network with participants exchanging data in a live clinical environment. And the health information network must be exchanging data in accordance with applicable federal and state law. Further, you must, the health information network must submit a plan in writing for how they will meet all of the requirements of the Common Agreement and the QHIN technical framework. Next slide. So step 1 in this application process is that the RCE will solicit, collect, and evaluate QHIN applications from health information networks who wish to receive QHIN designation. The RCE will then approve or reject the application within a stated period of time that will be identified by the RCE. And if approved, go to the next slide, please. If approved, both the HIN or both the Health Information Network and the RCE would sign the Common Agreement, and at that point, the Health Information Network would receive provisional QHIN status. The RCE would then assign the provisional QHIN to a cohort where it would receive technical assistance and guidance for implementing the requirements of the Common Agreement and the QHIN technical framework. At the end of the cohort period, the RCE would conduct testing to make sure the provisional QHIN has met all of the requirements. And if all of the requirements have been met, the RCE would officially designate the QHIN and provide written notice of this designation to both the QHIN and to ONC. Only then may the QHIN actively exchange data via the Common Agreement. Okay, great. Next slide. So now we're going to move into a discussion about some of the privacy and security requirements that are included in the Common Agreement. But first, I'm going to talk a little bit about some of the components that fit together to govern the Common Agreement and to create trusted exchange. So in designing the Common Agreement, we aim to create an environment where everyone that participates can play by the same set of rules. And in doing so, we had to take into consideration differences between the regulations that govern federal agencies, states, covered entities and business associates, and also new and emerging technologies such as smartphone apps that may not be HIPAA covered entities and business associates. So first and foremost, the Common Agreement aligns with applicable law, and that includes the HIPAA privacy and security rules, as well as any other federal or state laws. The Common Agreement does not, should not conflict with applicable law, and in the case of any conflict or inconsistencies, applicable law would take precedence. In certain places within the Common Agreement and the framework agreements, we then add an additional layer of protection above and beyond applicable law. So for example, where HIPAA applies only to protected health information, the Common Agreement and the framework agreements cover a broader set of information known as electronic health information. And we have expanded certain HIPAA provisions to apply to all electronic health information. In other places, we mirror certain HIPAA rules to apply to non-HIPAA entities that have voluntarily signed on to one of the framework agreements. So for example, we require that all QHINs, participants, and participant members, regardless of whether or not they are covered entities or business associates, abide by the minimum necessary rules from HIPAA when exchanging data. And then finally, QHINs, participants, and participant members are in no way limited from adding additional terms and conditions that go above and beyond what's in the framework agreements, as long as they don't conflict with the common agreement or the framework agreements. And all of these pieces come together to broadly govern trusted exchange and make it possible for those participating in the network to feel confident that the data that they are exchanging is safe and secure. So next slide, please. Okay, so next I'll talk about some of the minimum privacy and security requirements. So first, for QHINs, QHINs are the gatekeepers of all of the electronic health information on the network. And as such, they are held to a higher standard than the other participants and participant members, and they are required to abide by all of the HIPAA rules as if they apply to all electronic health information. So this is regardless of whether or not the QHIN is a covered entity or a business associate, they must abide by the HIPAA privacy and security rules. QHINs must also do an initial risk assessment and do this on an annual basis to test their security controls. Additionally, they must comply with the National Institute of Standards and Technology Special Publication 800-171, which are security standards published by NIST to protect electronic health information received from federal agencies. Next slide. The next, for participants and participant members, if they are covered entities or business associates, then they would still have to comply with applicable law and the HIPAA rules as they apply. But additionally, regardless of whether or not they are HIPAA covered entities or business associates, we are asking that these entities have minimum security controls in place to protect the confidentiality, integrity, and availability of electronic health information. So at this point, I'm going to turn it over to Alex Contour, who's going to talk a little bit more about the privacy and security requirements, as well as the exchange purposes and modalities within the Common Agreement.
Thanks, Zoe. So I'm Alex Contour. I'm an analyst with ONC's Office of Technology. I worked with Zoe on the minimum required terms and conditions and also led development of the first draft of the QHIN technical framework. Zoe already gave you a little bit of information about what I intend to cover, so I'll just dive right in. The first thing I wanted to talk about is identity proofing. And identity proofing, when we talk about identity proofing, we're really referring to a process by which we can establish the identity of an individual by verifying claims about them. And so the types of information we'd expect to see through identity proofing is stuff like, just the name, address, date of birth, contact information associated with an individual and provided in the form of evidence like a driver's license or passport. And basically the idea here is that we should be able to confidently link a claimed identity to the real world, real life existence of a person. And this is a really important first step in establishing that somebody trying to access electronic health information has the rights to do so. The Common Agreement refers to a document from the National Institute of Standards and Technology, or NIST, which establishes guidelines for identity proofing and also classifies identity proofing into 3 different identity assurance levels, referred to as IAL. We've proposed establishing a floor for identity proofing at IAL2, which might be conducted in person or remotely. The NIST publication provides instructions about the types of evidence required at level 2, as well as any validation processes, address confirmation requirements, and other requirements specific to the different levels of identity proofing. And so in short, everybody under TEFCA must be identity proofed at IAL2 before they can receive credentials for accessing or using any services. Moving on to authentication, this involves, next slide please. Authentication involves verifying a claimed identity, in this case after it's been identity proofed. we often encounter authentication in our daily lives when we do something like logging into a website using a username or password. Authentication is a really important component of access control, so that we can be sure that somebody who's asking for access to services is actually who they claim to be. Similar to identity proofing, the Common Agreement refers to another NIST publication which provides guidelines for digital authentication, including permitted types of authenticators and associated verification requirements. When I say authenticator, I'm talking about something like a known secret or a password, which can be used to indicate that the person trying to access services is who they say they are. The NIST publication, as similar to identity proofing, classifies authentication requirements into 3 different authenticator assurance levels. And we are proposing to set a floor for authentication at AAL2, which requires proof of possession of 2 different authentication factors before accessing or using any services. Next slide, please. So these next 2 provisions relate to the security of electronic health information. We have proposed that QHIN's participants and participant members comply with the breach notification requirements established by HIPAA. And so business associates and covered entities obviously have to satisfy any of the appropriate HIPAA requirements that apply to them. Non-HIPAA entities, on the other hand, have to meet the requirements set forth for business associates. Beyond that, in the event of a breach, we expect that all participants, participant members, and QHINs have to notify anybody else that they have a relationship with and who might be affected by the breach. And so just to provide an example of what I mean, a QHIN would have to notify the RCE, as well as any other QHINs, participants, participant members, and individual users that might have been impacted by that breach. In some cases, and this is probably edge cases for the most part, we do recognize that organizations might be subject to other breach notification requirements, such as those provided by the Federal Trade Commission and their health breach notification rule. This rule specifically applies to vendors of personal health records and other related entities. And we just wanted to emphasize that any of the breach notification requirements included in the Common Agreement don't supplant or replace any HIPAA or FTC reporting requirements or responsibilities. The other security-related provision that you can see here deals with electronic health information outside of the United States, and specifically prohibits QHINs from using or disclosing electronic health information outside of the US unless an individual user specifically requires them to. Likewise, if a QHIN utilizes any cloud services providers, they must be physically located in the US, and any electronic health information that a cloud services provider receives must be stored within the United States. We did specifically request comment on this particular provision, especially considering that there are federal agencies and other multinational entities that have employees receiving care outside of the US. Next slide, please. So as the TEFCA is implemented and more networks begin exchanging data, we expect to see increased demand for access to and use of electronic health information. Therefore, we wanted to ensure that individuals have the opportunity to understand and make informed choices about where, how, and with whom their data is shared. And so we've required QHINs participants and participant members to provide individuals with the opportunity to request that their electronic health information not be used or disclosed via the Common Agreement. Everybody under the TEFCA has to honor an individual's exercise of meaningful choice, as we've called it, and not use or disclose their electronic health information unless otherwise required by law. We also wanted to note that meaningful choice applies on a prospective basis, and this means that electronic health information may continue to be used and disclosed if it was already used and disclosed before the individual indicated their preferences. When a patient does opt out of exchange under the TEFCA, participants and participant members are responsible for communicating that decision to their QHIN, and that QHIN must then communicate it to all other QHINs. Also on this slide, we can see that the Common Agreement includes a requirement for all QHINs, participants, and participant members to provide patients with a written notice describing their privacy practices regarding the use and disclosure of electronic health information. This notice has to provide the same content as that which is found in ONC's Model Privacy Notice, which is published on our website. And it also has to include a description and example of each exchange purpose, provide information explaining how an individual can exercise their meaningful choice, and also provide information about who an individual can contact for more information about the entity's privacy practices. Next slide, please. I'll now turn things over to Don to talk a little bit about security labeling, our proposal for security labeling. Sorry about that. We did want to cover one other privacy-related consideration under the TEFCA. So when we talk about health information exchange, one topic that often comes up is the extent to which we can share sensitive health information, such as mental health or substance use disorder information, over a network. From our stakeholders, we've heard that a lot of health information exchange networks don't currently exchange sensitive health information because it's just too difficult to ensure that only the appropriate people can access that information. In the first iteration of the TEFCA, we requested comment about how to manage this type of exchange, and we received a number of comments requesting that we focus any requirements or any future requirements on using security labels. And security labels provide a mechanism for tagging data so that anybody who receives the data can understand restrictions on its use or disclosure. These restrictions might be based on things like regulations, such as 42 CFR Part 2, or based on privacy preferences indicated by an individual or a patient. So therefore, in a future iteration of the TEFCA, we're proposing to include a new requirement for the application of security labels to electronic health information that's being exchanged over the network. In short, this means that data holders under the TEFCA would have to apply security labels for any electronic health information that includes codes indicating one of three categories of sensitive information, those being mental health, substance use disorder, and HIV. Likewise, all electronic health information pertaining to minor patients would have to be labeled. We are specifically seeking comments on this proposal before adding it to the common agreement. And now we'll turn things over to Don, Dr. Rucker, to speak a little bit more.
Yeah, thanks, Alex and Zoe. You know, as we look at this before we get into some sample cases, I know at first blush it looks like a lot of complexity here, but I think when you unpack it, the way you would look at this, it's fairly simple, which is the QHINs are basically networks that are going to do the query and support of messaging across the entire country, right? Somehow we have to connect all the different things together. So that is the real function and distinction there. And then for the various participants sitting under those QHINs, we envision that those are often the health information exchanges as they sit today, with as minimal disruption and change needed as possible within the constraints of what Congress has made as federal law. And that the various types of participants give today's HIEs a fair amount of flexibility, as well as allowing new folks in. So I think when you look at that, think of the QHINs as doing the national, if you will, inter-process communication, and then the participants preserving as much of what is out there today and giving people as much choice and flexibility. As was emphasized, you don't have to do all of those things. There's a lot of flexibility built in there. And then think of the agreements. We anticipate most of these agreements will be standardized agreements under the common agreement. So this will not require, new lawyering and all that kind of stuff. We think most of these things are going to be very straightforward, network agreements, hopefully facilitated by a national understanding. Today, as folks know, each of the HIEs has had to negotiate this locally, often at great work. But I think with the overarching umbrella of the coordinating entity and federal law here, we believe that we have, in the spirit of what is explicit in the law, provided some assistance here. We look forward to your comments. So with that, let me turn it back over to the team.
Thanks, Dr. Rucker. So just wanted to switch gears a little and talk about how we can use the common agreement to actually exchange data. Under the common agreement, QHINs are going to be required to support a minimum set of exchange purposes and modalities to both send and receive electronic health information. And I'm going to talk about these over the next few slides. Together, these exchange purposes and modalities work to facilitate core use cases for interoperability, such as providing patients with access to their data, supporting care transitions, and some of the other goals and objectives that Zoe described earlier. Next slide, please. So as Zoe mentioned, the first iteration of the TEFCA did include a really broad set of required exchange purposes, and these were later adjusted in response to feedback from commenters. So ultimately, in this version of the common agreement, we're requiring entities to support exchange purposes of treatment, public health, utilization review, business planning and development, quality assessment and improvement, benefits determination, and individual access services. As in previous versions of the TEFCA, the proposed definitions of the exchange purposes often use language taken directly from the HIPAA privacy rule. And what this means is that most of the exchange purposes only apply to covered entities and business associates. There are two exceptions to this, which are benefits determination and individual access services, and both of these apply to everybody under the TEFCA. Individual access services in particular is one of the most important exchange purposes under the TEFCA because it's how patients can get their data. It applies to all electronic health information maintained under the TEFCA and supports two primary use cases. The first use case is the ability for patients to obtain access to their electronic health information from all of the places that they've gone for care. And the second use case enables a patient to direct a copy of that information to somebody else. We believe that individual access services is a critical component for empowering patients to play a more active role in managing and shopping for their care. QHINs, participants, and participant members have a duty to respond to all requests for electronic health information that they receive for any of these exchange purposes. However, there is one exception, and that's for entities that only provide individual access services. These entities only have to respond to requests for individual access services, not for the other exchange purposes. Next slide, please. So Zoe already discussed some of the changes to the exchange modalities in this version of the TEFCA, including the addition of QHIN message delivery and the removal of population-level data exchange. And so the three types of exchange that we're proposing all QHINs must support include two different types of query, one of which looks for electronic health information from a specific QHIN, and the other which looks for electronic health information from all QHINs, and also QHIN message delivery, which involves a QHIN sending electronic health information to one or more QHINs. QHINs have to support all three of these exchange modalities because it gives users the flexibility to request or send electronic health information in the most efficient manner to support a wide variety of healthcare needs. And just as an example of what I mean, a provider that's following up with a patient who's been hospitalized, they might want only electronic health information from that specific hospital visit, which would be a targeted query, whereas a provider who's seeing a new patient for the first time might want electronic health information from all of the providers that the patient has seen, which would be a broadcast query. Over time, ONC and the RCE may add new exchange modalities and exchange purposes to the common agreement in order to support additional emerging use cases. We think that this provides a phased approach that will allow the industry to adequately prepare for updates before supporting any new requirements. Next slide. So these next two slides illustrate just how some of the different exchange purposes and modalities work together to address real-world information exchange scenarios. So for example, imagine we have a primary care provider that works at a health system participating in a QHIN. That provider will see a patient for something like a rash and ends up referring the patient to a dermatologist for treatment. As part of that referral process, the primary care provider might want to make use of the exchange services available through this network to send a visit summary to the dermatologist so that that dermatologist will have all of the important information about the patient's health, their medications, the initial diagnosis, etc., when she sees the patient. So to accomplish this, the primary care provider could request QHIN message delivery for the exchange purpose of treatment. The provider would then send the visit summary to their QHIN, which would transmit the message to the dermatologist's QHIN, who would deliver the contents to the dermatologist. In our second example, a patient wants to use a smartphone application to gather her medical records from all of the providers that she's seen, and then use that application to aggregate those records into a comprehensive longitudinal view of her care. So to accomplish this, the patient logs into her smartphone application and requests all of her information from any providers that she's seen that participate in the network, using the exchange purpose of individual access services. The application's QHIN would initiate a QHIN broadcast query and ask all other QHINs on the network to find and retrieve any records associated with that patient. Each QHIN, or each other QHIN, would receive the request and then use its internal query methodology to find and retrieve appropriate electronic health information from participants and participant members. Each QHIN that found the patient's information would then transmit it back to the first QHIN, who would send the information through its network to the patient's smartphone application. Next slide, please. So that covers many of the essential aspects of the minimum required terms and conditions and the common agreement in its current form. In terms of next steps, next slide, please. We are looking for feedback on the second drafts of the Trusted Exchange Framework, the minimum required terms and conditions, and the first draft of the QHIN technical framework. So please do send us your comments at healthit.gov/TEFCA. The comment period for these documents, as well as the application period for the Notice of Funding Opportunity for the RCE Cooperative Agreement, are both 60 days long, beginning April 19th, 2019, and closing at midnight on June 17th, 2019. We will consider all comments and applications submitted on or before the deadline. Beyond the comment period, we expect to award the RCE Cooperative Agreement no later than September 2019. Once that cooperative agreement is awarded, the RCE is going to work to finalize the components of the common agreement for ONC approval, and those components again include the minimum required terms and conditions, any additional required terms and conditions, and the QHIN technical framework. These components will serve as the basis for the common agreement, and we expect to release the first draft of the common agreement for public comment in 2020, and then move as quickly to implementation as possible. Next slide, please. So that's all to say that we're really excited to engage with everybody about TEFCA, and we're trying to provide as many opportunities to do so as we can. You can find all of the materials that we talked about today on the links on this slide. And we're also holding another public webinar, this one focused on the Notice of Funding Opportunity announcement, on Tuesday, April 30th at 2 p.m. Eastern. And apologies for the incorrect date on the slide. That should be April, not June. We're also planning another webinar to answer questions about the TEFCA the following week or shortly thereafter. So please stay tuned for the exact date and time. Altogether, please do take some time to make your voice heard. Your feedback is really important to making this work, and we really do appreciate all of the engagement so far. Thank you.
All right, thank you so much, Alex, and thank you so much to our presenters, Dr. Rucker, Steve Posnack, Zoe Barber, and of course, Alex Contour. It was a pleasure to share with you a little bit about the Trusted Exchange Framework and Common Agreement Draft 2. As Alex said, we look forward to receiving your guidance, your feedback on what we've released. I also wanted to mention one other new release from HHS, which is the OCR, Office of Civil Rights, Frequently Asked Questions, related to the app environment and the right to access. It's available on the OCR, Office of Civil Rights website, and it relates to the application programming interface environment as it relates to Exchange, as well as to how apps can be used by patients to support their right to access. In addition, we also have 2 rules that are out for public comment at this time. One is the ONC rule, which relates to information blocking, as well as updates to the certification program and a number of other provisions, and CMS's interoperability rule. Both of those rules, the timetable for public comment has been extended to June 3rd. So with all of these pieces out, we look forward to the environment of interoperability that they will support in the coming years. And we thank you again in advance for your comments on these pieces. Thanks for joining us, and please tune into our upcoming webinars on TEFCA.